Good evening and welcome to Doctors on Call. It's not the diagnosis anyone wants to hear, but cancer is our topic of discussion tonight. What would you like to know about its prevention, diagnosis, and treatment? I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth. We're ready to take your questions locally at 218-788-2844 or toll free at 1-877-307-8762. And we have a great panel here to answer those questions. Dr. Lloyd Ketchum, an oncologist with the Essentia Health Cancer Center in Duluth, Dr. Emily Onello, a family medicine physician with the Lake Superior Community Health Center in Duluth and faculty member in the Department of Family Medicine and Community Health, Duluth, and Dr. Mikhail Perlov, an oncologist with St. Luke's Oncology and Hematology Associates in Duluth. Our medical students answering phones tonight are all Minnesotans. Paige Borst from Eagle Bend, Ashley Forstrom from Clara City, and Alex Sauer from Brainerd. And now on to tonight's program. So I think what we'll start, maybe Dr. Ketchum, just let's talk a little bit about some prevention strategies that we could use for cancer in general.
Sure. I think there's a lot of things that you can do to try to prevent cancers. The easiest, I think everybody knows, is not to smoke. I mean, that's probably the single biggest risk for developing a cancer. And then I think there are a lot of other things that can be very helpful that are just generally healthy activities. I think staying in shape and exercising and walking, having a good healthy diet, watching your weight. The things that are helpful for all the rest of your health are very helpful for preventing cancer.
That's helpful. Dr. Onello, why is family history important? When you see your doc, they usually ask you about your family history.
I think that's a good question for a number of reasons, even outside of conversations about cancer. But it helps to give us a sense of more of an individualized risk of what your ancestry and your genetics, if you will, might convey to you. So there's the general risk of certain cancers in age groups or genders, and yet your family may be at heightened risk because of a certain inherited trait. So it is good to know as much as you can about your blood relatives, and that may allow you and your physician to focus in on areas where you may want to have increased screening or awareness.
So are there certain family histories that we especially would look for, like colon cancer or breast cancer, Dr.
Well,
Perlov?
surely. The breast cancer is probably the cancer that most well known right now about the familial risk of it. But colon cancers and surprising number of other cancers that are associated with certain familial genetic conditions. So that actually we ask a lot of questions every time we see a patient, and we forward patients often to genetic counselor because that field has gotten quite complicated.
So we have some questions already coming through. So Dr. Ketchum, I'll ask you. So the first question might be a little more difficult. It's from Duluth, and they're asking about an inner ear cancer. So maybe like a cholesteatoma or something in the inner ear. They're just asking, explain it.
Okay. That's hard for me to give a really clear answer without knowing a little bit more about it. That would be an unusual place to develop a cancer. It's not something that commonly occurs. It would be something that you'd have to talk through with the doctor that was taking care of you about what's the pathology, or where did it come from? Did it come from the skin area, or did it come from a nerve in the area? And then work through what kind of treatment strategies you might be able to think about doing. I mean, and it was really, a lot of it's going to end up depending on what does it look like under a microscope.
That's a little hard one right to begin with. So we'll go to a little bit helpful question. Dr. Onello, about colonoscopies. So can you talk a little bit about how we would screen people for colon cancer and the use of colonoscopy?
Yes, well, it's an interesting question because I think there's been some rapid activity in that area in terms of alternatives to colonoscopies. But generally speaking, we look for colon cancer generally in the older population. I believe the guidelines would suggest we start looking at age 50, although it is one of those cancers we discussed earlier that if there's a strong family history or you're of a certain ethnic group, you may want to start screening sooner. So the colonoscopy is a visual inspection of the colon looking for precancers. It's one of those, I think, exciting areas for primary care because we have an opportunity to find a growth or a polyp at a point where it has not become a cancer. And usually there's some time allowed there, so if you get your screenings early, we believe that these growths unattended may take over 5, 10, 15 years time to transform into cancer. So it's really an opportunity to in a sense, prevent a cancer. And certainly the other screening modalities have a place as well for those who can't have a colonoscopy for some reason.
So Dr. Perlov, I know Mayo has a new one recently, the Cologuard. Can you talk a little bit about that?
Not about the details, really. Just generally other modalities other than colonoscopy that exist are virtual colonoscopies using imaging. And additionally, you have screening tests that detect blood presence in the stool earlier than the tumor may be felt symptomatically. Additionally, now there are tests that probably Cologuard is about to detect the DNA of the tumor in the stool that can be specifically identified and leading to earlier detection of threatening problem.
Good. Dr. Ketchum, when we're diagnosing breast cancer, can you talk a little bit about how we do that or what protocols we utilize to make that diagnosis?
Sure. So breast cancer diagnoses predominantly today are made based on abnormal mammograms. Most of the women who are diagnosed with breast cancer now are getting picked up on a screening mammogram. And on the mammogram, they can see calcifications, which are just little deposits of calcium in the breast. They can also see masses or deformation of the tissue in the breast. And then those can be biopsied and identified whether there's a cancer there. And the vast majority of cancers are detected that way. There are a group of women who will occasionally feel a palpable lump, and they're always very much encouraged to visit with their physician about it. Really, what my guidance to people is to have what we call breast self-awareness. And many of the guidelines are kind of changing from personal breast exams to just understanding what your breasts feel like so that if something changes, you can bring it to somebody's attention. And those end up being sometimes cancers that don't necessarily show up on a mammogram. And there's a few kinds of breast cancer that just are not easily seen on a mammogram, but they'll have a palpable abnormality and then they can have an ultrasound and we can diagnose it that way.
Dr. Perlov, once we've made a diagnosis of breast cancer, how do you, as oncologists, decide on the treatments?
So it depends on the several parameters. I try to teach my patients about the first, middle, and last name of a cancer. And last name describes where the cancer comes from and what the appearance is under the microscope. The first name is what usually is known as the stage, which is one of the big determinants of what can be done for the cancer up front. And then the middle name is the biological parameters, biological characteristics of each cancer. In the case of breast cancers, there are 3 that we commonly use. It's 2. It's a hormone receptor status and the presence of a growth receptor called HER2. But in any cancer, we involve 3 specialists routinely: surgeon, radiation oncologist, and medical oncologist. And the size of the tumor for breast cancer and the presence or absence of the lymph nodes that are abnormal are the primary determinants of does the person go for surgery up front or does medical oncology treatment is needed beforehand.
Very helpful. So an interesting question, Dr. Onello, asking about a patient, what if a family member wants to keep the diagnosis to themselves? Kind of historically, that has been the issue. I think that's probably less of an issue now, but any comments about that?
Well, I commend the caller for bringing up that question. That's always challenging, and I think my colleagues would agree. That's a difficult one to answer in that I think that there's a lot of values and cultural norms and priorities in that. I think certainly the way we see things, at least in our practice here, is that the patient, the person who's been diagnosed with cancer, does have that right to decide if they want to tell family members, if they want to share that. And certainly each person's situation is different, and hopefully they can work with their healthcare team to get the support they need should they decide not to disclose that diagnosis to the family.
It's very helpful. So Dr. Ketchum, let's change topics just a little bit. And a caller from Duluth is asking about PSA, or prostate-specific antigen testing, and why we're going away from routine testing. How do we make those decisions? That might be another question.
Yeah, I mean, it's the whole, it's part of a bigger topic, which is the reevaluation of screening in general. And I think prostate cancer and what's been happening in prostate cancer screening recommendations is interesting as kind of a lesson in that. The issue with the PSA is it's a very good test for identifying early prostate cancers. Anytime you think about a screening test, in an ideal world, you'll have a simple test and then you'll have an effective treatment for something that's going to cause you a big problem, if that makes sense. Mm-hmm. And so in prostate cancer, one of the issues that people have found is that many of the prostate cancers that are picked up on screening have a long natural history and a relatively benign course. And the treatments for prostate cancer have a set of complications associated with them in terms of the surgery and or the radiation, in terms of sexual function, in terms of bladder and bowel function. And so if you look at very large groups of people and you screen them all, it starts to look like you actually probably cause more harm than good. Mm-hmm. That being said, there are some prostate cancers that would be really good to pick up early. And so there's this constant friction between what should we do. And I think ideally at some point we'll have a test that's much better at picking out the patients that have a really big problem that we can impact in a meaningful and helpful way from the people that probably would rather not know about this because it's not frankly likely to cause them a problem.
That was most helpful because it really does cause friction. That's a nice term to say, because we'd like to pick up the ones that we know are going to be a problem and be more aggressive with treatments.
And I think that it's the screening things and the screening recommendations that have been coming out have been, I think, very challenging for patients, and there's been a lot of confusion, and lots of different organizations have been trying to have input into what should we do, and we end up with many, many answers, which at the end of the day actually aren't really all that different, but it's very confusing to people, and I understand that.
Well, I think it's important to understand that the screening recommendations have several levels to them. One level is a societal health. How do we find most people with potential problem? But the second level, or just as important, is a personal level. When we tell a person that they potentially have a serious issue, how does that impact their life? How does that impact their future? And sometimes those are in conflict. Mm-hmm. That's what you're just pretty much reflecting on. Mm-hmm.
Well, and then we have certain criteria that we've been doing for years, and then all of a sudden we change, and the patients are used to those preventative screening tests, and they've changed suddenly. So.
Well, and I think it's important to understand that medicine is a continuously evolving field, including the screening tests, and if the guidelines have changed, there is a reason for that there has been new information because our lab tests are changing, our imaging quality is changing, technology for colonoscopy changes, and all these may lead to a change in the guideline. It's a routine process for us to alter what we do based on new information, based on new evidence. And I think the safest thing for the patient is, with a concern like this, is to address it with the primary care physician to start with. Most primary care physicians are very interested in the high quality screening tools to prevent big problems, and they will be able to address these questions very effectively.
I'd just like to thank you and echo that. I think a lot of patients I hear sort of, when guidelines change, they assume that means, well, those doctors just don't know what they're doing. You know, oh, this has changed, it's different, it's up, it's down. And it's the opposite. I think you articulated that beautifully, that it's in light of new information and more further, deeper thought on things. So thank you for that.
So Dr. Onello, maybe talk a little bit about when you see a patient and they have concerns about a cancer, what kind of symptoms would you be looking for that would lead you to do a workup for a possible cancer, like especially if somebody's coughing or has problems breathing?
No, I think that's a good question for your viewers. There are some generalities, but before I answer, I do want to say that many of the symptoms that can represent a cancer can also represent another condition aside from cancer, such as an infection or an autoimmune condition. So certainly coughing, unexplained coughing that's lasting longer than your typical cold might go, bronchitis might go, unexplained fevers and chills, really a dramatic change in your appetite, loss of energy. And one that I would certainly be concerned about would be unexplained weight loss. I mean, many of us are trying to lose weight, but if you're a person who's losing weight without trying and without other explanation, that'd certainly be a reason to come in and have further evaluation. I guess the other part of that answer would be what type of cancers we'd be thinking of. Certainly a skin cancer might be a change or something new on your skin, as opposed to something inside the skull or the brain. Might be more headaches or unexplained headaches or problems with numbness or weakness. So it can be a lot of things, but the general things I mentioned would be the things that certainly come to my mind first.
Most helpful. So Dr. Ketchum, so another caller from Two Harbors is asking about referred pain. And if you have referred pain, is that a symptom of a cancer? So kind of building off of Dr. Onello's comments.
I mean, it can be. I mean, you can get referred pain, but what that basically means is that your body's interpreting a pain as being someplace because the nerves aren't providing clear information about where it is. And so, I mean, that can occasionally happen in cancers, but usually it's pretty evident on an imaging study, you know, where it's coming from or how that's happening.
So this is an interesting question, Dr. Perlov, about if it's possible to get cancer of the heart.
Yes, there are several types of cancers that can originate in the heart, and there are maybe a couple of tumors that can spread as a metastasis to the heart, melanoma being one of the prime examples.
So maybe talk a little bit about metastasis, Dr. Ketchum. So if we have a basic diagnosis like a colon cancer, what are we talking about when we talk about metastasis?
So metastasis is basically when a cancer leaves where it started and shows up somewhere else. And that's in some ways the biggest problem with cancers is when they metastasize. What happens is that the cancer cells grow in a way that allows them to invade into either the lymphatic system, in which case they'll show up in a lymph node, or into the blood system, in which case they circulate through the blood system, and then they land somewhere. And when they land somewhere, they'll release things that allow them to develop their own blood supply, and then they can grow there. And many of the treatments that we have for metastatic cancers are directed at trying to interrupt that process in different ways.
Well, Dr. Onello, a caller from Duluth asking about platelet counts. Can a low platelet count be a sign of cancer?
Okay, that's a good question. Again, the same caveat, low platelet counts can be from a variety of reasons, even a viral infection, but I would answer that yes, particularly cancers that are affecting where platelets are made or bone marrow, blood cancers, low platelets can be a sign of cancer, yes.
So Dr. Perlov, just a little bit of explanation about if you have a cancer and you're seeing an oncologist, and please, Dr. Ketchum, jump in on this as well. How do people get into clinical trials?
So first let's explain what a clinical trial is. So the clinical trial is a regimented way of introducing a new combination of a new treatment or a new approach into the clinical practice. It's regimented because we really need to know who to apply the treatments or imaging or something new on, who is the right patient, and what degree of benefit do we expect. So the clinical trials are a cornerstone of our advancement in oncology. Most medications we use now, 99% have been through clinical trials, have proven track record of effectiveness against specific type of cancers. So we run clinical trials, and the way we're usually trained at big academic institutions is if you have a clinical trial, that's what you want to do for a patient as long as you expect a benefit. It's very easy in either of our cancer centers. If the patient comes and we have appropriate clinical trial for them, it will be offered to them as an opportunity to participate in. The benefit is directly to our patient, but also to the people who will be seen by us in 5 to 10 years when the results are in. New, people would consider miraculous treatments for some types of cancers. There was this patient number 1, 10, 15 years ago, who got that drug for the first time and got the benefit. Now we use them as standard, but when the patient comes for clinical trial, they will help somebody in the future, for sure.
It's a nice reason why a lot of people like to participate. Would you like to add anything to that?
Yeah, sure.
Dr.
I mean,
Ketchum?
I think that it's pretty easy to be involved in a clinical trial. We have a whole panel of clinical trials open. We're a member of the Alliance, which is one of the big cooperative groups. And the way it works is that clinical trials, a lot of academic centers and other oncology centers come together and put together a group of trials in an effort to get enough people enrolled on the trial in a timely manner. And so I think most of the cancer centers have clinical trials open, and I know we definitely try to keep them open in almost every disease. And I really encourage people to think about it. I think it can be a really useful way to be treated. When you look at the data, people who are treated on clinical trials do better than people who aren't. I mean, and we've shown that over and over again. And so I really would encourage people, if they're offered a clinical trial, if there's an applicable clinical trial, to think about doing it. I think that that's often one of the best ways to get your care, and I think it could be helpful and beneficial to the patient themselves, in addition to helping us to have information to treat people better in the future.
Well, I think it's very important. The concern that we hear often from our patients is they don't want to feel like they're lab rats. And this is really not what the purpose of our clinical trials is. The ones that are offered by our cancer centers have been already tested to the level of the human. And most of the clinical trials are just fine-tuning our understanding of how to give the drugs safely and what level of benefit to expect from them. This is actually our offering of clinical trial is an attempt to do better than the standard of care. That's why we offer a trial to as many people as we can.
And safety monitoring is completed, so patients are actually very safe and watched very closely.
And I think especially in today's environment, there are some pretty exciting new drugs coming out which are not available clinically. The FDA hasn't necessarily approved them yet, and sometimes those are only available in the context of a clinical trial. Sometimes they're available for another disease, but if they haven't been shown to be effective, the insurance companies aren't going to pay for them. And so, I mean, I think that there are a lot of really exciting treatments out there that are available in the context of clinical trials. And I mean, I really encourage people to think about it as part of their own care.
Totally agree. Any words to add, Dr. Onello, as far as decreasing people's risks for cancer? We have about 1 minute.
Well, sure. I think we've touched on some good things. I guess as a family physician, to remind people that there's a lot of the internal things, such as you mentioned about eating well and exercising, but also external things, using your sunscreen. minimizing exposure to environmental toxins as much as we can. I think last month was radon testing month, so get your house tested. You don't want to be breathing that gas if you can avoid it. Things like that, avoiding pollution, and just, I think those are the things I tend to encourage my patients to do.
Well, very good. Well, thank you very much, panelists. Our time is up. I want to thank our panelists, Dr. Lloyd Ketchum, Dr. Emily Onello, and Dr. Mikhail Perlov, and our medical students, Paige Borst, Ashley Forstrom, and Alex Sorer. Please join Dr. Ray Christensen for next week's program on geriatric care, which also happens to be the last program of our season. His panelists will be Dr. Mark Boyce, Dr. Amy Greminger, and Dr. Addie Lakari. Thank you for watching. Good night.